Hello. In this video today, we'll be talking about the pathology of the prostate gland. The topics to be covered in this video are histology of prostate gland, diseases of the prostate. We'll understand the terms such as benign prostatic hyperplasia, what happens in the carcinoma of prostate. We'll also learn about the Gleason scoring and look at the role of PSA screening in the context of Ca prostate. What is the prostate? It's an accessory reproductive gland in the adults, weighing about 20 grams. There are about 3 lobes, 2 major lateral and a small median lobe. In the histology, it's comprised of acini or glandular component embedded in a fibromuscular component. The epithelials are comprised of 2 layers of epithelial and basal cells. So these are the acinar component, what you find here, and we have the basal cells, and you have a fibromuscular stroma. Normally, the prostate will have corpora amylaceae within it. The prostate is comprised of 2 zones. The inner periuteral part is sensitive to estrogen and progesterone, and androgen, whereas the outer subcapsular part is sensitive to androgen. So the inner part is sensitive to estrogen and androgen, outer part to the androgen. All right. And that has significance when we talk about carcinomas and BPH. We will come to that. Which are the common diseases of prostate gland? We have prostatitis, nodular hyperplasia, and carcinoma. Prostatitis, any itis means inflammations. We're talking about inflammation of the prostate gland, and we can have acute. It can be of chronic origin or granulomatous. Right? We will see them one by one. So acute prostatitis can happen as a part of ascending urinary tract infection. You'll have the infection spreading from the urinary bladder upwards to the right from the urinary bladder. It can spread upwards through the ureter to the kidneys, or it can spread downwards. It can spread downwards and involve the prostate gland. It can also occur as spontaneously or as a complication of the urethral manipulation of the prostate gland. The common pathogens are E. coli, Klebsiella, Proteus, gonococci. They are the common organisms causing urinary tract infection. Chronic prostatitis affects men above the age of 40 years. It is of 2 types, bacterial and abacterial. The chronic bacterial prostatitis is comprised of 10 to 12 pus cells in a prostatic secretion with bacteria. In abacterial, as the name suggests, they will have leukocytosis without bacteria. Then you also have granulomatous prostatitis with leakage of prostatic secretions. The gland is firm in origin, comprised of inflammatory reaction, comprised of macrophages, lymphocytes, plasma cells, and some multinucleate giant cells. Now coming to a very important entity, a very common condition, common in men above 50 years of age, usually presenting with incomplete evacuation of bladder, a sense of fullness even after evacuation in the men. We're talking about a condition called benign nodular hyperplasia or adenomyomatous hyperplasia of prostate. Above the age of 80 years, 75 to 80% of the people are suffering from the symptoms of urinary tract obstruction. Surgical intervention is required in about 5 to 10%. What is the etiology? There is endocrinological factors, racial, inflammation, arteriosclerosis. BPH is androgen dependent. Dihydrotestosterone mediates the prostatic growth, synthesized from testosterone with the action of 5-alpha reductase. Therefore, 5-alpha reductase inhibitors help in reducing the DHT, dihydrotestosterone content, and thereby decreasing the prostatic volume and urinary obstruction. Estrogen plays a role by rendering the cells susceptible to the action of dihydrotestosterone. The tension of the prostate smooth muscle is mediated by alpha-1 adrenoreceptors localized to prostatic stroma. Thus, alpha-1 adrenergic receptor antagonists cause relief of urinary obstruction. How does the gland appear on gross? It is enlarged, nodular, smooth, firm, weighing about 2 to 4 times its normal weight. Cut surface in the primary glandular BPH is yellow-pink, soft, honeycombed, with milky fluid exudates. Fibromuscular BPH is firm, homogeneous without milky fluid. So on gross, you find the gland made up of nodules of varying sizes, it's firm, rubbery, and the urethra can be having slit-like space, which can be compressed. And you find all these nodules here, which are firm, right, compressing the urethra. This is the nodular hyperplasia of the prostate. So in the context, what happens here, if you see, you have the prostate gland here, you have the urethra, and you have the bladder. When there is hypertrophy, urethra, what happens? It gets compressed and slit-like. Back pressure forces the bladder to undergo hypertrophy, and there is detrusor muscle hypertrophy. Therefore, one of the ways to treat BPH is to give relaxants even to the bladder. They give muscle relaxants to the bladder as well as alpha-1 adrenergic receptor antagonists so that the ease of urination happens. In microscopy, what you find is hyperplasia, if you go by definition, is an increase in the size of an organ resulting from increase in the number of cells. Therefore, you will have an increase in the two-layer cells of inner columnar and autocuboidal. You might have with fibromuscular hyperplasia and other benign findings like squamous metaplasia, lymphoid aggregates, corporomalacia, squamous metaplasia. All those things are also visualized. This is the findings of basically it's the increase in the number of glands and the stromal component. That's why it's called benign prostatic hyperplasia or adenomyomatous hyperplasia. And clinical features, there will be urethral obstruction with secondary effects on the bladder like hypertrophy and cystitis and hydronephrosis. There is increased frequency of urine, nocturia, difficulty in micturition, hematuria, that is blood in the urine, as well as acute retention of urine. Another specimen showing you the bladder with thickened hypertrophic trabecular wall, back pressure causing dilatation of the pelvic calyceal system, thinning of the corticorrhea, and these are the features of benign prostatic hyperplasia with hydronephrosis. Other conditions of the prostate, you have the prostatic intraepithelial neoplasia. That is a pre-malignant condition. And you have cytological atypical luminal cells in the prostatic duct. You can have low-grade PIN as well as high-grade PIN. Right? They are important, especially in core biopsies. They can indicate malignancy elsewhere. Coming to carcinoma of prostate, it's the second most common form of cancer in males, common in men above 50 years of age. 50% of men, if above 80 years of age, have a latent cancer, right? So the etiology can be endocrinological factors, racial, geographical, environmental influences, nodular hyperplasia, hereditary conditions. Let's see them closely. Endocrinological factors, evidence supporting role of androgen in tumor. So when we do orchidectomy, it causes the arrest of metastatic prostatic cancer. Administration of estrogen causes arrest of prostatic cancer. Carcinoma of prostate is extremely rare in Klinefelters and eunuchs who do not have the androgens and begins at a stage when androgen levels are high. Etiology, racial, geographic, high among the Americans, uncommon in Japanese and Chinese. Environmental influences like high dietary fat, exposure to polycyclic aromatic hydrocarbons. Other etiologies, you have the nodular hyperplasia that can be a putative precursor to prostatic cancer, and hereditary conditions can also cause the prostatic cancer. Now coming to we have discussed the continuum of lesions from PIN to low-grade PIN, high-grade PIN adenocarcinoma. On gross, you will have an enlarged prostate gland, which can be normal in size or small in size, located in the peripheral zone. So remember, Ca prostate is more common than peripheral zone. All right. So we always advise our residents that whenever you get a TURP chip, look at the smaller chips because they are the ones which have been taken from the periphery. All right. Then among the architectural pattern, you have the Gleason patterns. And in the Gleason patterns, what do we have? Pattern 1, 2, 3, 4, and 5. There are 5 different patterns. 1 and 2 no longer exist. They are not called as malignant anymore. So we start with the pattern 3, 4, and 5. We'll look at them, right? And how does it spread? It can spread through the prostatic capsule to the bladder neck, seminal vesicles. It can spread to the back. Okay, the lymphatic spread can happen. Osseous metastasis can happen to the pelvis, lumbar, spine, lungs, kidney, breast, and brain. So you can have urinary obstruction, dysuria, retention of urine, hematuria, pain in the back due to skeletal metastasis. Which are the tumor markers you will do? Prostate acid phosphatase, and PSA, prostate-specific antigen. 4 to 10 nanograms per ml is highly suspicious. Above 10 nanogram per ml is diagnostic of prostatic cancer. So you have a triple approach: digital rectal examination, serum PSA determination, and transrectal ultrasound-guided core biopsy. Very important for the pathologist and for the urologists is the Gleason's histological grading. You have degree of glandular differentiation, and now there are only 3 patterns which exist: grade 3, grade 4, and grade 5. Right? So this no longer exists. We start from the grade 6, or score 6, where it is grade 3 plus 3. So we always give it in duplicates. So if it's we look at the core biopsies or the prostatectomy specimen, we look at the 2 patterns which are most predominant, and we then give the grade plus grade is equal to score. So if we find a recent grade 3 and the 3 pattern, it becomes 6. 7 can be 4 plus 3 or 3 plus 4. Likewise, you can have 8, which is 4 plus 4. And you can have a 9, which is a 5 plus 4 or a 4 plus 5. And then you have a 10. Gleason score is the sum of the 2 most prevalent Gleason grades, primary and secondary, designated according to the separate rules for biopsy and prostatectomy. If only one pattern is present, we, as I told you, will give it as primary and secondary pattern together as 3 plus 3 is equal to 6. In core biopsies, however, we have to see the different anatomical. We have to grade each core separately, right? And the highest score may serve as a basis for determining type. In radical prostatectomy, score should be based on the primary and secondary pattern. And if a minor pattern constitutes less than 5%, that should be mentioned as a tertiary pattern. Any high-grade minor pattern greater than 5% should also be incorporated in the Gleason score as the secondary pattern. All right. So example, if there is a Gleason pattern 3 of 96%, but pattern 4 and 4%, then your score is still 3 plus 3 is equal to 6 with the minor tertiary pattern 4. However, if the score is a pattern 3 of 95% and a pattern 4 of 5%, your score will upgrade to Gleason score 3 plus 4 is equal to 7. That needs to be noted for the radical prostatectomy. In needle biopsy, however, the most prevalent pattern is graded as primary, and any amount of worst pattern is graded secondary, because we do not have the whole specimen. The idea is you're getting a small pinch of tumor. Any amount of small pattern, you have to take it as a secondary pattern, right? So example is, in both the cases, which I've quoted earlier, the score will be 3 plus 4 is equal to 7. You're upgrading it because you do not have the whole specimen with you, right? So you're upgrading it, and in this case, the score, the 3 plus 4 is equal to 7. 3 plus 4 is equal to 7. You're taking any amount of worst pattern as the secondary pattern for a needle biopsy. For a radical prostatectomy, that was not the case. It had to be more than 5%, as I told you, for it to be accounted for as the secondary pattern. So these are the Gleason groups. Score 3 plus 3 is equal to 6, 3 plus 4, 7, 4 plus 3, 7. Then you have a score 8, which is 4 plus 4 is equal to 8, or 3 plus 5, or 5 plus 3. And score greater than 9 is the 5th category. 4 plus 5, 5 plus 4, 5 plus 5 is equal to 10. Greater or equal to 9. That's the 5th category. So histologically, over the years, we have seen patterns change, and the latest consensus is that branching glands should be included as Gleason 3. Cribriform is always 4. Okay, and presence or absence should be specified for 3 plus 4, 4 plus 3, or 4 plus 4. Globulite variant is always 4. Mucinous, depending on the growth pattern, is important. Don't see the mucin. Could be 3, 4, or 5. Small cell, we do not grade. Intraductal, we do not grade. Intraductal associated invasive cancer, include in estimating the grade, percentage of the grade 4, instead of keeping it separate. Right? And ductal, if ductal components are there, it doesn't apply now. Adenoid cystic, we do not grade. So what is important for me to tell you is that glomerulite is now 4, cribriform is now 4. All right, that you have to remember. And mucinous not important. The pattern is important. And intraductal associated with invasive, include in estimating the percentage of grade 4, and don't keep it separate. So it's more or less simplified now. This is the Gleason grade 3 pattern, another 3 pattern, and grade 4 fused glands I've seen here, right? Fused glands. Cribriform is a grade 4. Again, fused glands. Grade 5 individual cells are there, small cells dispersed or comedonephrosis necrosis type. Now coming to the importance of another test, total PSA and free PSA. So you should have to understand that the natural aging process increases the size of the prostate gland and consequently raises the quantity of total PSA in the blood. However, patients with prostate cancer have less of free PSA, therefore have a diminished PSA percent ratio. All right. So that is important of free PSA. The percentage is important, and when the free PSA by bound PSA ratio decreases, it is likely to indicate a malignancy. All right. So to summarize, what we have discussed in this video was, we talked about the prostate gland. We talked about conditions such as benign prostatic hyperplasia. We understood that the benign prostatic hyperplasia can cause urinary obstruction, and if left untreated can even cause pressure on the bladder and the kidney through hydronephrosis. So it's important to address the condition, not necessarily by surgery, but it could also be addressed by medicines. We studied about the prostate cancer. We know it's a very important form of cancer in the men, and it can cause metastasis. And prostate cancer can also be estimated by a triple approach of digital rectal examination, PSA estimation, as well as by a transrectal ultrasound guided biopsy, core biopsy of the prostate. We studied about the Gleason grading of prostate. You know now how to estimate the Gleason grades. It starts from 3. So grade plus grade is equal to score. So 2, grade 3, grade 4, grade 5. 1 and 2 do not exist anymore, right? And we have seen the different patterns. All right. This is just an introductory video to prostate. We can have more specific videos in the future on each condition in greater depth and a case-wise approach. Hope you enjoyed watching this video. Thank you.